Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 184 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, PLC, a 44-year-old male patient with HIV and HCV co-infection, genotype 1A, non-serotic, receives approval to initiate therapy for HCV with sofosbuvir and velpatasvir. He has no known drug or food allergies. He has a past medical history significant for GERD, hypertension, HCV and HIV. His current home medications include amlodipine 10 mg orally once daily, calcium carbonate 750 mg orally thrice daily PRN, abacavir 600 mg plus lamivudine 300 mg plus dolutegravir 50 mg orally once daily. So my question to you is, when discussing the HCV therapy with the patient, which of the following information is most important? Is it A. Hold antiretroviral therapy while completing HCV therapy, or B. Separate calcium carbonate from HCV therapy by at least 4 hours, or C. Take the HCV therapy with a full meal, or is it D. If your heartburn symptoms worsen with therapy, switch from calcium carbonate to esomeprazole 40 mg once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Separate calcium carbonate from HCV therapy by at least 4 hours. This patient is taking sofosbuvir R plus velpatasvir. The use of proton pump inhibitors, such as esomeprazole, is contraindicated with velpatasvir because they can decrease the velpatasvir serum concentration. This patient is taking sofosbuvir plus velpatasvir, which may be taken without regard to food intake. Doses of this medication and calcium carbonate should be taken at least 4 hours apart because antacids may decrease the serum concentration of velpatasvir. This patient may safely take antiretroviral therapy for HIV, tenofovir lefenamide plus emtricitabine and atazanavir plus cobicistat with HCV therapy, sofosbuvir velpatasvir, because there are no drug interactions. Please advance to the next question. And the next question reads, DEF, a middle-aged patient weighing 82 kg, is currently on week 4 of ledipasvir plus sofosbuvir plus weight-based ribavirin therapy for hepatitis C virus infection, genotype 4 to be specific. He reports to hospital today for the results of lab tests. His pertinent labs include AST and ALT of 39 and 76 international units per liter respectively, HCV-RNA less than 15 international units per milliliter, hemoglobin of 8.7 grams per deciliter, a hematocrit of 26.2%, a WBC 10.1 times 10 power 9 per liter, a platelet count of 22,000 per millimeter cubed. So my question to you is, which of the following regimen modifications would be the most appropriate for DEF at this time? Would it be A. Reduce the dose of ribavirin, or B. Increase the dose of ribavirin, or C. Permanently discontinue ribavirin, or D. Continue ribavirin at the current dose? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Permanently discontinue ribavirin. Ribavirin therapy should be permanently discontinued because of the platelet count 22,000 per millimeter cubed, because it is less than 25,000 per millimeter cubed. Please proceed to the next question. And the next question reads, TJP, a 26-year-old male presents to the free clinic with concerns that he might have been exposed to hepatitis A virus HAV due to an outbreak reported at a restaurant where he regularly eats snacks and dinner. Regarding his history of past illness, he reports last eating at the restaurant about 30 days ago. He denies any signs or symptoms of infection and is otherwise in good health. He has a past medical history significant for bipolar depression. Regarding his sexual history, he is a heterosexual male, who drinks alcohol occasionally with friends. He currently takes no medications. Regarding his vaccination history, he is up to date. He is allergic to sulfur drugs, and the last time he took a sulfonamide he developed hives or rashes. His pertinent vital signs include a body temperature of 97.9 degrees Fahrenheit, a heart rate of 78 beats per minute, a respiratory rate of 14 breaths per minute, a blood pressure of 114 systolic and 72 diastolic. He rates his pain as 0/10. His height is 5 feet 11 inches. His weight is 81.4 kilograms. His serologies are as follows: HIV negative, total HAAB, positive HBsAg, negative HBcAb, negative HBsAb, positive HCVAb, negative. So my question to you is, which of the following would be the most appropriate recommendation for TJP now? Would it be A. No action is needed at this time, or B. The patient should receive a HAV booster vaccine, C. The patient should immediately initiate post-exposure prophylaxis with immune globulin, or would it be D. The patient should initiate vaccination against HAV? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. No action is needed at this time. The patient does not need to initiate HAV vaccination because he already has active immunity. The window for initiation of HAV post-exposure prophylaxis, exposure within the past 2 weeks, has passed. Immune globulin is not indicated for this patient because he already has active immunity to HAV. Because the patient is already immunized against HAV, an additional booster of HAV vaccine will not provide any benefit. Because the patient is already immunized against HAV, no action is needed at this time. Please progress to the next question. And the next question reads, which of the regimens listed below is recommended for the management of a treatment-experienced patient with genotype 1b hepatitis C virus, HCV infection and decompensated cirrhosis who previously received PEG interferon and ribavirin but stopped taking ribavirin due to intolerable adverse effects? Is it A. Sofosbuvir plus velpatasvir plus varxalopravir, or B. Sofosbuvir plus velpatasvir, or C. Ribavirin plus sofosbuvir, or is it D. Glecaprevir plus pibrentasvir? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Sofosbuvir plus velpatasvir. Glecaprevir pibrentasvir is not recommended for the management of patients with HCV infection and decompensated cirrhosis, so it is not an appropriate choice for this patient. Sofosbuvir plus velpatasvir is one of the recommended treatments for patients with genotype 1 HCV infection and decompensated cirrhosis. It is the best choice for this patient. Ribavirin plus sofosbuvir is not considered a recommended treatment for genotype 1 HCV infection in treatment-naive individuals. Because this patient has decompensated cirrhosis, cimeprevir plus sofosbuvir is not an appropriate choice. Although sofosbuvir plus velpatasvir plus varxalopravir is pan-genotypic for treatment-experienced patients with HCV infection, it is not indicated for patients with decompensated cirrhosis. Please advance to the next question. And the next question reads, JKK, a 25-year-old female patient is admitted to the hospital with a seizure which was secondary to benzodiazepine withdrawal. JKK completed successful treatment for hepatitis C virus, HCV infection with ledipasvir plus sofosbuvir 30 days ago. He has a past medical history significant for substance abuse, asthma which is well controlled, hepatitis B virus (HBV) infection, and bipolar depression which is well controlled. His current home medications include valproic acid 500 mg orally twice daily, sertraline 50 mg orally in the morning, fluticasone propionate 45 micrograms co-formulated with salmeterol 21 micrograms per inhalation, HFA inhaler dose to 2 puffs twice daily. Her pertinent labs are as follows: a glucose level of 101 mg per deciliter, a BUN of 19 mg per deciliter, a serum creatinine of 1.2 mg per deciliter, sodium levels of 131 milliequivalents per liter, potassium levels of 3.1 milliequivalents per liter, chloride of 93 milliequivalents per liter, and albumin of 2.6 grams per deciliter, AST and ALT of 125 and 102 international units per liter respectively. A total bilirubin of 2.1 mg per deciliter, and valproic acid concentration of 100 micrograms per milliliter. Her serologies are as follows: HIV negative, anti-HAVIG, M positive, HBsAg positive, HBsAb negative, HBV DNA 37,551,458 international units per milliliter. Baseline prior to HCV treatment was undetectable, HCV-AB positive, HCV-RNA undetectable. Baseline prior to HCV treatment it was 12,564,231 international units per milliliter. So my question to you is, which of the facts listed below best explains the most likely cause of JKK's HBV reactivation? Is it A. use of high-dose fluticasone propionate co-formulated with salmeterol therapy, or B. recent completion of ledipasvir plus sofosbuvir therapy, or C. a supratherapeutic concentration of valproic acid, or is it D. excessive benzodiazepine use leading to withdrawal? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. recent completion of ledipasvir plus sofosbuvir therapy. Excessive benzodiazepine use followed by withdrawal is not considered a likely cause of HBV reactivation. A boxed warning in the FDA-approved labeling for ledipasvir sofosbuvir about the risk for HBV reactivation, fulminant hepatitis, hepatic failure, and death was issued for all patients co-infected with HBV and HCV who are undergoing or recently completed HCV direct-acting antiviral therapy and are not receiving treatment for HBV. Recent completion of ledipasvir sofosbuvir therapy is the most likely cause of HBV reactivation in this patient. The valproic acid concentration is therapeutic and the patient's bipolar disorder has been well controlled using this medication, so this drug is an unlikely cause of this patient's HBV reactivation. Chemotherapy, solid organ or bone marrow transplantation, rituximab, high-dose corticosteroids, anti-tumor necrosis factor agents, and discontinuation of HBV treatment are other possible causes of HBV reactivation. Recent completion of ledipasvir sofosbuvir therapy is the most likely cause of HBV reactivation in this patient. This patient's asthma has been well controlled by fluticasone propionate plus salmeterol. Fluticasone 180 micrograms per day by oral inhalation would not be considered high-dose corticosteroid therapy for an adult. Although high-dose corticosteroid use can cause HBV reactivation, this patient's asthma has been well controlled by fluticasone propionate plus salmeterol. Please proceed to the next question. And the next question reads, DWO, a middle-aged patient is starting treatment for hepatitis B virus HBV infection. So my question to you is, what medication education should be provided to DWO prior to initiating therapy? Is it A. patients initiating tenofovir disoproxil fumarate should be cancelled on the drug-drug interaction and avoidance of rifamycins, or B. patients initiating tenofovir alafenamide should be cancelled on drug-drug interactions and the avoidance of phenytoin, or C. patients receiving tenofovir alafenamide should be cancelled on the development of flu-like symptoms when initiating therapy, or is it D. tenofovir alafenamide and adafovir should be used in combination based on their high rates of virologic suppression? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Patients initiating tenofovir alafenamide should be cancelled on drug-drug interactions and the avoidance of phenytoin. Adafovir and tenofovir alafenamide should never be used in combination. The same holds true for concomitant use of tenofovir disoproxil fumarate. Flu-like symptoms are an unlikely side effect from tenofovir alafenamide. These symptoms are much more commonly associated with pegylated interferon. Concomitant use of tenofovir alafenamide with phenytoin may result in reduced tenofovir alafenamide concentrations, decreased efficacy, and the emergence of resistance. The likely mechanism behind this is phenytoin induction of P-glycoprotein, a transporter involved in tenofovir alafenamide disposition. Rifamycins are not contraindicated with tenofovir disoproxil fumarate, but they are contraindicated with tenofovir alafenamide-based products. Please progress to the next question. And the correct answer is, in which of the following asymptomatic patient populations in the United States is routine testing for latent tuberculosis, using tuberculin skin testing and/or interferon gamma release assay, most appropriate? Is it A. patients admitted to a skilled nursing facility, or B. immigrants from countries with a high burden of tuberculosis, or C. hospital nursing staff, or is it D. American students entering schools of pharmacy, nursing, or medicine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Immigrants from countries with a high burden of tuberculosis. In 2017, the rates of tuberculosis in non-US born immigrants were 15 times higher than in US born residents. Therefore, routine testing for latent tuberculosis in asymptomatic individuals is most appropriate for immigrants from countries with a high tuberculosis burden. Rates of tuberculosis, latent or asymptomatic, in the general U.S. population are low, so routine testing for latent tuberculosis in asymptomatic American students entering schools of pharmacy, nursing, or medicine in the United States is not as appropriate as testing of populations at higher risk, such as immigrants from countries with a high tuberculosis burden. In a population with low incidence of true positive of tuberculosis, false positive tests constitute a higher proportion of all positive tests, therefore the positive predictive value is low. Please advance to the next question. And the next question reads, DDM, a middle-aged male patient with newly diagnosed tuberculosis initiates treatment with multiple antitubercular drugs administered daily. Isoniazid is part of this regimen. The chest physician is concerned about possible neurological adverse effects from isoniazid. So my question to you is, which of the interventions listed below would you recommend to reduce the likelihood of neurotoxicity in DDM's clinical scenario? Would it be A. Instruct DKK to take his isoniazid thrice weekly rather than daily? B. Instruct the DKK to take his isoniazid with meals to slow the rate of absorption, or C. Ask DKK to contact the prescriber if he develops altered mental status, or would it be D. Initiate pyridoxine 50 mg orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Initiate pyridoxine 50 mg orally once daily. Peripheral neuropathy is a known adverse effect associated with isoniazid. Adjunctive treatment with pyridoxine is recommended to prevent the development of peripheral neuropathy. Although patients should be instructed to notify the prescriber about a change in mental status, adverse effect probably is not caused by isoniazid. The rate of absorption of isoniazid is not expected to influence the likelihood of neurotoxicity from isoniazid. All antitubercular drugs should be administered on a daily basis, especially in the early, intensive phase of therapy. Please advance to the next question. And the next question reads, which of the statements listed below would be a key educational consideration when developing a case management plan for a patient treated for tuberculosis? Would it be A. providing scientific articles and book chapters to help patients gain insight into their disease, or B. ensuring that the patient knows the best time of day to take his or her medications, or C. educating the patient about tuberculosis and its treatment, including adverse effects, or would it be D. differentiating cavitary from non-cavitary pulmonary tuberculosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. educating the patient about tuberculosis and its treatment, including adverse effects. Although the presence or absence of cavitary disease may influence the duration of therapy, it is the duration of therapy, not the presence or absence of cavitary disease, that should be emphasized to the patient. Patient-centered therapy is a cornerstone of effective treatment of tuberculosis. In addition to ensuring that the patient has good insight into the disease and its management, healthcare providers should discuss expected outcomes from treatment, specifically the potential for cure of the disease, methods for supervising medication administration and assessing the response to therapy, and infectiousness and infection control measures. The most convenient times for medication administration can be established based on caregiver and patient needs to facilitate compliance. There is no best time of day that is appropriate for all patients. Communication should be face-to-face using language that is understood by the patient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 185.